Professor Georgiafas, thank you very much indeed for your kind words. And of course, for this marvelous opportunity to be with this marvelous team here with you and to discuss about this pandemic, the COVID-19 pandemic, but also to understand how this virus and this disease is to some degree related to cardiovascular system and how this virus tries to create such a huge cascade which cardiovascular system is of course very much involved. So saying that, we have to recognize that COVID-19, although it was believed that it's primarily a respiratory disease, progressively we have recognized that this disease is a little bit more systematic and the cardiovascular system is highly involved. Here are my disclosures. Actually, I have nothing to declare related to this topic and to this presentation. And first, allow me to discuss a little bit cardiovascular involvement in COVID-19 and how the pathophysiological mechanisms related to this area could be analyzed. First is, of course, the viral invasion. And since we have the viral invasion, we have recognized that it is a systematic inflammation, not only to lung tissue, but also to cardiac myocardium. And of course, this inflammation involves endothelial cells. Since these complex mechanisms are developed, we could summarize, talking about the cardiovascular system, the following. So, some key points. The pathobiology of coronavirus infection involves SARS-CoV-2 binding to the host receptor angiotensin converting enzyme to mediate entry to the cells. This is very well known. ACE2, which is expressed in the lungs, heart, and vessels, is, of course, a key member of the renin-angiotensin system, important in the pathophysiology of cardiovascular disease and in general, actually, for the functioning of the cardiovascular system. Cardiovascular disease associated with COVID-19 is highly possible that involves dysregulation of the RAS-ACE2 system. Cardiovascular disease may be primarily being a phenomenon of COVID-19, but it is highly possible also that it could be a secondary phenomenon because the acute lung injury, which leads to an increased cardiac workload, potentially problematic in patients with pre-existing coronary artery disease and or heart failure. So, as the demand in oxygen are increasing, and as there is a lung infection and lungs problems, you understand easily that we are facing a vicious cycle here. Cytokine release storm also exists, originating from imbalance of T cell activation with dysregulated release of interleukin 6 and 17, and of course some other cytokines. So all these different contributors are combined to a catastrophic event. Chronic cardiovascular disease, such as coronary artery disease, but also heart failure. As you know, heart failure in many cases is a secondary phenomenon of coronary artery disease also, may become unstable in the setting of viral infection as a consequence of imbalance between infection-induced increase in metabolic demand and reduced cardiac reserve. Talking about patients with coronary artery disease and heart failure, we have to highlight here that they are in a particular risk because there is another possibility. Because the increase of shear stress and the inflammation, we have a high possibility for a plaque rupture secondary to virus infection, and because as a result to the systemic inflammation. Procoagulant effects of systematic inflammation also may increase the likelihood of stent thrombosis. Just now we had the opportunity to listen Professor Spiropoulos, and of course he so nicely presented to us the prothrombotic effect of the coronavirus infection. So through these 3 paragraphs, you could easily understand the huge really systematic involvement of different parameters in this catastrophic event. But again, if I would like to highlight here the most important areas of concern, then I would like to highlight here the procoagulant effect of systematic inflammation. And of course, I would like also to highlight here the systematic and high possibility of plaque rupture secondary to the virus infection. Talking about mechanisms, I would like to present also in very brief, of course, some plausible mechanisms of myocardial injury. And we have to take into consideration that during this infection, during this the period of this problematic development, we have apoptosis and necrosis of myocardial cells. We have myocardial ischemia, and of course, we have seen a lot of coronavirus patients developing myocarditis. During this myocardial ischemia, and again, I would like to emphasize here the fact that there is hypoxia and there is an inflammatory activity within coronary plaques and ruptures. Saying that, we could ask a main and significant question. Is myocardial injury an independent predictor of an increased mortality in COVID-19 patients? This is the main question. We have a number of trials, especially coming from China, which have replied to this question. And the answer here is, of course, yes, there is an association of cardiac injury with mortality, with an increased mortality in hospitalized patients with COVID-19, as it was proven, as I said, in a number of trials, especially coming from China, in Wuhan. For example, this one by Shi, Chabot, and his colleagues, published recently in JAMA Cardiology 2020, has proven this reality, that those patients without cardiac injury had a higher survival versus the poor survival, as it is here, of those patients with cardiac injury. So please keep in mind that we have 2 main categories of patients diseased by coronavirus. Those who have developed a cardiac injury, as it is proven by high levels of troponin, and those patients without any kind of injury. And of course, the prognosis of the second group is much better. So, if we would like to conclude around this first topic, I would like to say that myocardial injury is significantly associated with fatal outcome of COVID-19. Let's focus now to the second topic of this presentation, acute coronary syndrome admissions during COVID-19. This is really a very important issue, and it was published in many papers, and it was discussed among a lot of specialists. And during this time, especially during the lockdown, we have seen and we have recognized a paradox. And here, I would like to present in brief some key findings of an ESCL, European Society of Cardiology survey, focused on this topic. The survey included 3,100 respondents in 141 countries on 6 continents. 58% of respondents were based in Europe. This survey revealed that one of the main consequences of the pandemic and the lockdown was the dramatic reduction of STEMI or non-STEMI patients at the emergency departments. Indeed, 78% of respondents perceived a decrease in a number of STEMI and non-STEMI patients coming to the hospitals. 62.3% of respondents declared that STEMI patients presented later than usual at the emergency department. This is really very important. So we have recognized that during this period of the last few months, it was a significant reduction of the patients with STEMI or non-STEMI presented in the emergency departments. And here there is another scientific paper coming from Greece, published recently by Professor Choufis, and the title of this paper was "The Mystery of Missing Visits in an Emergency Cardiology Department in the Era of COVID-19. As it is clear here, in this area, the number of the patients with acute coronary syndromes presented in the emergency departments of the Greek hospitals was really very, very few. There are many explanations about and around this reality. The first possibility is that patients were fearing to come to the hospitals and to get, because they felt that they would be infected. Of course, for many others, it was another reality that we should discuss. It was the reality that social distancing and economic lockdown, it was possible that resulted in lower levels of physical activity, lower level of shared stress inside the vessels, and all these different possibilities had led to less triggering of cardiac symptoms and less triggering of acute coronary syndromes results. Last of these 3 topics that I would like to present today, it is the therapeutic management of acute coronary syndromes during the COVID-19 pandemic. It is a fact. We have recognized that during the last 3 months, during the peak of the crisis, it was an obstacle course of reperfusion of STEMI in the COVID-19 realities. Why we had this obstacle? Obviously, because it was a fear between the patients to go and to be examined in the emergencies. It was, of course, another reality that the phone lines were saturated because it was such a panic between a number of persons, a number of patients. It was because the availability of the ambulances to run fast and to pick up the patients with STEMI and non-STEMI was less important, actually less available, and everything was sluggish, and of course it was even a restructuring in all the hospitals to admit more COVID patients, and that's why the service in the cardiology department in many cases was a little bit more sluggish and a little bit more difficult. Here, it is an algorithm showing how the patients with STEMI, but also without STEMI, non-STEMI, had managed during COVID-19 pandemic. First, let's examine STEMI network. All these network, all these patients used to go to the hospitals using an ambulance. These patients were transported to the hospitals, as I said, with the emergency ambulance, and then in the hospitals, these patients had been grouped according to the emergency, according to their characteristics, and some of those enjoy primary PCI, and some others were treated by fibrinolysis. In general, in the hospitals, we have recognized 4 different groups of STEMI cases. The first group was STEMI, or very high-risk non-STEMI patients without COVID-19, and or known that these patients had contacted an infected subject. Healthcare professionals, we have recognized that should wear the standard PPE and like surgical mask, gloves, cap, goggles, and single-use gown. The second group of STEMI, or very high non-STEMI patients with COVID-19 suspected symptoms and or known contact with infected subjects or confirmed infection treated at home. In this second group, the healthcare professionals should be protected much more effectively. And we had, of course, a third group of STEMI in the hospitals that we have to deal with all those. This group was STEMI, or very high risk non-STEMI, in patients hospitalized in the hospitals for COVID-19 infection. And of course, we had a fourth group, very difficult group, STEMI or non-STEMI, complicated by cardiac arrest healthcare. And here the healthcare professionals had to work under pressure with a number of difficulties. And of course, all these healthcare professionals should be protected very effectively. Now, looking to the British National Health System, we have recognized that the system there was quite clear, addressing to healthcare professionals. And here we have summarized some orders, some guides, clinical guidance for the management of coronary artery disease patients during the coronavirus pandemic. The National Health System in Britain ordered to the healthcare professionals saying, elective in patients' day case activity, you have to be elective. All elective admissions should be deferred unless absolutely necessary. Okay? So the patients with coronary artery disease, but without something extremely urgent, should be deferred for a second time to be catheterized. PCI, elective PCI should be deferred also according to British National Health System. What about non-STEMI? Patients need to be assessed on a case-by-case basis. You see? What about primary PCI for STEMI? We know, of course we know, everybody knows that patients undergoing primary PCI via the radial approach have significantly higher rate of reperfusion, better left ventricular function, fewer complications, and are more likely to have a short, uncomplicated hospital stay. So everybody knows nowadays that primary PCI is much more effective for those patients with STEMI. By contrast, giving thrombolysis may seem lower risk, but the dilemmas raised in those, about 25%, who fail thrombolysis in terms of whether they had then to go to the cath lab or not. Please note that there are strong voices coming from many others saying that a door-to-needle time of 30 minutes, door-to-needle means that from the patient door to needle of thrombolysis, okay? So a door-to-needle time of 30 minutes may be more achievable than a door-to-balloon time to 90 minutes. So we have to take into consideration that under these very difficult times, when we had to check if the patient coming to the hospitals and to the emergencies was suffering or not from COVID-19 infection, under these very difficult circumstances, for some cases, especially for non-stemming cases, it was much more preferable the treatment to be thrombolysis, because thrombolysis could be offered earlier in a time of 30 minutes, Doortoneedle. The mortality benefit associated with primary PCI may be lost if door-to-balloon time was more than 1 hour. So we have to balance. We had to balance. In conclusion, in the present global COVID-19 pandemic, a cardiovascular emergency was faced, balancing between the urgency of the event, the safety of other patients, and also the safety of the medical professionals. Again, if I would like to summarize here the realities, for STEMI dramatic cases, we had to go to primary PCI under very well-defined conditions, very good protection of the healthcare professionals. For non-STEMI patients, thrombolysis for many of us was much more important. Saying that, I would like to thank you for your patience to listen to this rather complex presentation. Thank you very much indeed.